And welcome to the Davies being presented by Cleveland Clinic on hypertension improvement. This is a Davies Award winning use case for the value of health IT. I'm the manager of quality and patient safety. It's my pleasure to moderate this presentation. Core use of health IT to improve care delivery advocates the integration of clinical decision support and access to clinical data to analyze progress, and IT-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information technology to improve patient outcomes and value. The Davies Awards winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health IT-enabled care delivery. So it's my pleasure to welcome our speakers from Cleveland Clinic today.
Hello, I'm the Nursing Director in Ambulatory.
Hi, I'm Dr. Family Medicine at Cleveland Clinic.
Hi, I'm a physician in internal medicine at Cleveland Clinic.
Go ahead.
Okay, and today and talk about Cleveland Clinic's Hypertension Improvement Project, also known as 16K and 16, so-called because our goal was to help 16,000 additional Cleveland Clinic patients with high blood pressure get their blood pressure under control in 2016. Hypertension is preventable and treatable chronic diseases in the United States. 70 million Americans have hypertension. It's the #1 risk factor for premature death, mostly from strokes and heart attacks, which results in $46 billion in excessive healthcare spending. We know our country needs to spend less money on healthcare, and insurance payment models are moving towards rewarding value. Improving the care for our patients with hypertension is a key component, and in Medicare's Accountable Care Organization Shared Savings Program, hypertension control is one of the required quality metrics, known as metric ACO 28. Approximately 160,000 patients with hypertension in our Ohio and Florida locations. As of January 2016, about 68% of those patients had their last recorded ambulatory blood pressure less than 140/90. Our goal of achieving 80% required 16,000 more patients to achieve blood pressure less than 140/90. If we would have reached this goal, we would have 650 fewer strokes, 500 fewer heart attacks, and avoid 375 premature deaths. Communicating this dramatic impact on our patients' risk reduction continues to be a powerful motivator of improvement. Cleveland's population is around 400,000 total patients who were seen at 51 different locations, supported by 300 primary care physicians, multiple advanced practice providers, 50 RN care coordinators, 6 social workers, and 8 clinical pharmacists. Patients detected to have elevated blood pressure during office visit is for a clinical intervention and planning to occur during the visit to help the patient achieve normal tension. Then have the patient follow up in one of many appropriate settings every 2 to 4 weeks for reassessment until the patient reaches their goal. If a patient falls out of this cycle, registries can identify them and trigger outreach. The workflow requires highly functioning, well-trained teams working together in a safe, trusting environment with the common goal of caring for the entire patient, supported by technology and visual management. The technology platform centers on our electronic medical record, EPIC, with Optum One, which can provide actionable reports based on information within the EMR and billing. Patients is facilitated by patient education videos provided by Emmy, auto-dial telephone messages provided by Televox, and electronic messaging provided by Epic's MyChart functionality. KN16 Hypertension Improvement Project was provided by the leadership of Cleveland Clinic's Quality and Safety Institute and Medicine Institute. As we coordinated the technology, supported the infrastructure development, and offered training and best practice sharing to champions from every location. The champions then created excitement and improvement at their local site. We met with the champions quarterly and coordinated monthly conference calls. Our primary outcome measure was ACO 28, the percentage of patients with blood pressure controlled at their last ambulatory visit, less than 140/90. In addition, we provided each practice location 3 key process metrics to help them move the needle. Number 1, what percentage of their patients with elevated blood pressure were scheduled and seen for reassessment within 30 days? Number 2, the number of patients whose last blood pressure was elevated and have not had a recent visit. And number 3, what is the percentage of patients who had an initial high reading at an office visit and had their blood pressure rechecked again during the visit? We know the second reading done later in the office is often normal and can spare the patient from unneeded intervention. Patients were given monthly reports on these 4 metrics so they can gauge their own progress and compare themselves to their colleagues at different Cleveland Clinic sites. Very importantly, patient information was available to be used for local targeted outreach. Local outreach done by a PCP's team is very powerful, especially when done along with the appropriate bulk population ordering. This graph shows our baseline performance of 66 to 68% of our patients with well-controlled blood pressure. If we put this graph back further in time, as we saw earlier, you would see a very flat line. Our existing system was producing the consistent results it apparently was designed to produce. During 2016, with our intensive improvement efforts, we improved to 74% and have maintained this improvement through 2017. Additional organizational improvement is necessary to improve beyond our new plateau in order to reach our goal of 80%, which has been achieved by many of our practice sites, but not by the system as a whole. Again, 3 key interrelated areas of focus were addressed. Our most important resource, our people, our caregivers who touch our patients every day. Our goal was to train the frontline staff to identify elevated blood pressure correctly and be equipped to encourage and direct the patient through the treatment plan. The process is the workflow, and we wanted to provide infrastructure and tools to make it easy for the caregivers. And last is the technology to provide analytics and registries to integrate seamlessly into the workflow. The process needs to be obvious and self-apparent for it to become a normal part of the day in a busy primary care office with multiple priorities. Any process which feels like extra work is not sustainable. The typical definition of a hypertension cohort would be to include patients with hypertension listed on their problem list, which for us is around 120,000 patients. Using technology and analytics, we identified patients with hypertension who did not yet have the diagnosis listed on their problem list. This group of patients is key for outreach and engagement efforts, as they may be at higher risk of falling through the cracks and having suboptimal blood pressure control. We identified around 40,000 patients in this category, expanding our cohort to 160,000 patients. These patients with possibly undiagnosed hypertension were found through clinical and claims data. They had either an encounter claim of hypertension on at least 2 occasions or had blood pressure greater than 150/90 on at least 4 separate encounters. Our ambulatory care dashboard, again showing our performance in the ACO 28 hypertension outcome measure. The dashboard is updated monthly for all the ACO clinical quality metrics and is available for all caregivers to view, performance by the Cleveland Clinic Enterprise, and then drill down to their department and position level. And now I will hand off to Ruth Ann.
Thank you. Various forms of visual management were created to help connect the caregivers with this initiative. This included posters and newsletters, which provided the site champions with reminders, as well as demonstrating the impact to the patients through fewer strokes, heart attacks, and deaths. The site challenged to develop bulletin boards at their practices as a means of sharing data with team members and keeping the momentum going. And you can see from this photo, there are different bulletin boards from various practices. There is a relation between a major role in moving this initiative forward. Teams that had significant improvements were recognized and rewarded with things such as pizza parties or ice cream luncheons. As part of it, it's essential that the licensed and unlicensed caregivers knew how to correctly measure blood pressures, and technology was utilized to assist with this. Completed a demonstration competency, and this has now become an annual requirement. The standard was also established to recheck the blood pressure prior to the end of the office visit if the systolic was greater than 140 or the diastolic greater than 90. Lastly, caregivers were re-educated on how to document blood pressure readings in the electronic medical records. Blood pressures were rechecked only about 30% of the time. During the first quarter of 2016, there was a rapid upswing in rechecks, and this was due to various interventions that were implemented, such as setting the new standard, the competency education, sharing the data with the teams, and even holding the monthly site champion meetings. Since May 2016, the recheck rate has continued to improve and actually held steady with approximately 65% recheck rate. Thousands of blood pressure readings from the different offices. This graph shows that the blood pressure readings were often being rounded off anywhere from 15 to 50% of the time, and this could definitely result in unnecessary interventions for the patients. One would expect a normal distribution to be about 20% of the time where blood pressure readings would end in a zero. This further demonstrated the importance of ensuring correct documentation. Fisher?
Thanks, Ruth Ann. So getting our caregivers up to speed and educating them on how to take a proper blood pressure and follow up accordingly was definitely the foundation of where we started, but engaging our patients in self-management was an important part as well. We knew from the beginning that we would have to be more creative in the ways that we reach out to patients to get them as a more active part of our caregiver team. The first thing we did was create an improved after-visit summary education. The after-visit summary at the Cleveland Clinic prints automatically after every ambulatory visit, and so the patient is given this information at checkout. We set our after-visit summary up in the project to print a blurb at the end that you'll see on the screen in front of you if the patient has known hypertension and the blood pressure was elevated at the current visit. This across the entire enterprise, and we got good responses from patients and questions, knowing that we set forth with the understanding that our care teams would address every elevated blood pressure at every visit, but also realizing that there would be gaps in that recommendation, and this was one more way that we would help capture those patients. It's interesting to see feedback from patients when they read that their goal would be 140 over 90, and in fact, perhaps at that visit it was elevated. And we got a lot of great feedback to our care providers from patients saying, hey, what's going on with my blood pressure? Should we check it again, or when's my follow-up supposed to be? So this was really helpful. Another was to push them towards the Emmy modules. These are web-based videos that would explain both the background of hypertension, but also review goals and ways that patients could engage themselves to better control their blood pressure. Over the course of the project, we sent out almost 88,000 invitations for our patients to go to the Emmy website to view the module. Almost 24,000 of those programs started, and many of them completed. We received in feedback over 4,000 surveys, and this patient feedback really was telling. As it shows on the screen in front of you, 82% of those patients indicated that they will take action to manage their own health. 81% said that they now were more aware of how their lifestyle impacts their health. And an additional 81% also indicated that they were more motivated to change their lifestyle. Apart from the percentages, we also got a lot of verbatims from the ME feedback that was really cool to see as well. Patients said things such as, "It was a great presentation, it was informative but not judgmental, it was good, it gave me information that I might not have asked my doctor." And so this was good for us to see as a core team to then take that back to our providers to allow them to provide better education to those patients. The other was incorporate better visual management. We knew that a lot of times providers, even though a patient might have an elevated blood pressure at their visit, might surpass it if the visit wasn't specifically for a chronic follow-up for blood pressure. Maybe if they were rushed for time, they might have a patient in the office with a blood pressure greater than 140/90, but they might miss it. And so in order to better get that information in front of our providers, we engaged in visual management in a couple different ways. One, so in every patient encounter in our electronic health record, the vital signs project in a banner just above the patient information. That banner includes information like their weight, their blood pressure, their pulse, but historically, even if the blood pressure was elevated, it would project just as the same as all the other numbers. But we made a slight change to the electronic record during our project where if the blood pressure was either greater than 140 systolic or 90 diastolic, it would turn red and bold. And so this made it a little more obvious to the provider and might take better attention to that blood pressure. We also instituted a new patient list view in a provider's schedule daily. They would be able to add a column that would show the patient's last blood pressure. And this might be used at a meeting with the medical assistant and the teamlet in the morning, or it might be used on a rolling basis throughout the day. But it at least got those blood pressures in the view of the provider more readily. That way they could take action if necessary. Another thing that we wanted to try to figure out was how to get these patients back in if they had elevated blood pressures. We wanted to be creative with our care teams and utilize all of our providers to the highest level of their caretaking ability. The one thing we do was institute a new nurse blood pressure visit clinic order. So if a patient is seen in the office and the provider feels like that patient needs to come back in to be seen for another blood pressure check and maybe a titration of medications, but doesn't necessarily have time on his or her schedule, they could coordinate a follow-up visit with a nurse. And if they use this standard order to give instructions to those follow-up visits, the nurse might be able to titrate the medications on their own per protocol. So what you see in front of you is a standard order entry for nurse blood pressure visit. The physician or provider of the day could include some instructions for how that visit's going to go. And then at that nurse visit follow-up, 30 days later, they would have access to those instructions and be able to titrate medications accordingly. An internal process metric that we had was to get these patients back within 30 days. We know that if patients are seen every 6 months and elevated blood pressures are noted, that their control is not going to be optimal. And we made a standard metric of 30 days as that follow-up. With a baseline around 35%, we saw pretty quickly over the first few months of our project that baseline rose to between 45 and 50%. And it stayed there pretty much throughout the entire year. We had a small dip at the end, but we're starting to trend back up in the right direction. We also realized, being a multi-specialty institution, that some of the blood pressures that we saw on our patient charts came from our specialty offices and not from primary care. And so we had a very extensive outreach effort for our patients for blood pressures that perhaps were last noted to be above 140/90 that were not in our office and not exposed to our standard follow-up protocols.
So in the blood pressure control workflow that was illustrated in the beginning, you may recall that there was one arm of that for non-office visit encounters. So as we move as an organization to try to manage our entire population, whether it's for patients who are able to come in for office visits as well as for those who aren't, we needed to develop the process and the technology to enable our caregivers to also focus on the patients who flag with high blood pressures outside of office visits. To do this, we had to leverage big data and turn this into usable tools for our front lines. And fortunately, we were able to combine our clinical and financial data, as was described earlier, and we run that through an analytics engine called Optum1, in order to not only define those cohorts so that we're not just focusing on patients who have hypertension on their problem list, but people who clinically also have it based on multiple elevated blood pressures. And from there, we're able to identify the specific care gaps. So in this case, it might be that the blood pressure was uncontrolled at the last visit, but we also had an opportunity, based on our caregivers' feedback, to try to manage the whole patient to find care gaps from other chronic diseases or potentially even wellness care gaps that hadn't yet been closed. And so this was the task that we undertook in terms of the creation of a single registry to manage our population called our Care Gap Registry. So this started with first determining which chronic diseases did we want to focus on in terms of, number one, defining the cohorts, and then number two, finding those patients who had evidence-based care gaps within those cohorts. These were the conditions that were initially picked, and all of them represent the combination of the clinical and financial data that we've referenced earlier in order to get a more accurate sense of which patients have which chronic diseases. And then all of those cohorts were combined into the single registry with the relevant care gaps flagged on them. The example of the registry is seen here. So each of these lines at the top is an individual patient, and you can see there's some relevant data about them, including who their care team is, when their appointments are. But then each of those chronic diseases we just mentioned are an individual column. A blue dash means they don't have that chronic disease. A green check mark means they have it, but they've satisfied the evidence-based care gap for that chronic disease. And then the opportunity for us was the red X's. That means the patient has the chronic disease but has not satisfied the evidence-based care gap. So for this first patient at the top, you can see that they have a diabetes-related care gap open, but have closed their AFib, congestive heart failure, and hypertension-related care gaps. The bottom half of the screen represents specific information about the individual patient selected in the registry. So this allowed us to have a bird's-eye view of our entire panel, and to facilitate the work of the frontline caregivers, or the entire team, I should say, that was charged with closing these care gaps, we provided the additional tool of bulk communication. So whether it was through the use of MyChart for patients who were signed up, or auto-dial text messaging or email for patients who weren't, this was an ability to message multiple patients with a single click, and as a result, promote the efficiency of our frontline care teams. The last process we wanted to make sure we addressed was how to monitor blood pressures in between visits. What we've described so far was flagging blood pressures that might have occurred elsewhere in the system and populating them on a registry. But the actual home monitoring was something we also wanted to address. And so this started with a concerted effort to make sure that we built a technology link between machines that were monitoring patients at home, whether it was blood sugar monitors or blood pressure monitors, through their smartphones and straight into our electronic health record. And to take it even one step further and have the electronic health record have decision support available to analyze the trends in those data that were coming in and flag opportunities for our frontline caregivers to intervene. During the course of this hypertension effort, which was the first time we were really testing out this process, we did a virtual hypertension pilot. So this initially started with ensuring that a group of patients each had a Bluetooth-enabled blood pressure cuff, which connected to their phone and then into their MyChart, and as a result would be in our electronic health record. In addition, we had dedicated providers who would perform virtual visits with those patients, and as well as intermittent visits with health coaches virtually. And we saw that for this very challenging population that we initially enrolled, that was only 46% in control, that rose modestly to 54% through this limited intervention. That is now graduated to a phase 2, which is all of the above, with the addition of a clinical pharmacist, and importantly, the ability for our frontline care teams to be able to directly refer into this program for home monitoring and further integration of those home results. So going back to our ideal state workflow, you can see here that we've reviewed the technology that was needed to enable each of these process steps. So Ruth Ann mentioned the blood pressure rechecking, the terminal zeros. Corey was talking about the blood pressure on the header and the schedule, as well as the ME functionality and automating the orders for our members of the care team. In addition, on the bottom pathway here, you can see that we were using big data and analytics to be able to drive that information into our electronic health record, so it was at the fingertips of our caregivers. We've learned a lot of lessons as we tried to integrate technology into our processes and have it support our people. Most importantly, no matter how great the tools were that we were providing, there was a fear of change. And so we had to address both the rational as well as the emotional case for change here. And a lot of that was inspired by this construct that you see in the bottom right from a book called Switch, which has some very simple approaches to how to promote change and that we found very helpful. We also wanted to leverage the fact that each of our 51 practices had local innovations, and we had an opportunity to have each of them be testing grounds, and as long as we had built an environment to make sure that we could share those best practices across the system, we could enhance the innovation. Importantly, this effort was a lot about introducing our providers in particular to team-based care and to get them more comfortable and trusting of other members of the team, such as the nurse to do nurse blood pressure visits, the pharmacist to manage medications, as well as the virtual team to work with the patient. And then finally, we had to balance many ongoing change efforts with this one, but as you saw, there were significant results that we were able to achieve for our organization and for our patients. In terms of a technology investment, it was relatively modest. The interventions that we described in total were probably half a year of one FTE of a technical person, roughly $50,000 of technology investment. This acknowledges the fact that we already had our EHR in place, that we already had an analytics engine in place. So, of course, those are to be considered as well. But for our organization, the payoff was significantly more. So, as was mentioned earlier, this was hypertension was one of our key opportunities for our ACO in terms of an area of improvement. And the year prior to the start of this intervention, we were only able to garner 87% of the totally eligible quality points. With this hypertension effort, as well as other improvement efforts, we were able to increase that in our second year of our ACO. And because we also were able to clear our benchmark in terms of shared savings, this improvement in quality translates to roughly a $3 million increase in terms of a distribution for our ACO. But perhaps more important for our caregivers and for our patients is the impact that we've had on their health. So this modest 8% rise that we saw in hypertension control translates to about 10,500 additional patients than we had prior with controlled blood pressure. And using commonly available numbers needed to treat, we predict that this will translate into 131 less strokes, 100 less heart attacks, and 75 less early deaths for this population. In summary today, we hope that we've illustrated that the use of technology was vital in our improvement efforts. We were able to take our big data and analytics and have it be available at the front line to make decisions. We were able to provide tools to improve the efficiency of our caregivers. And importantly, we're able to reach our patients in different ways through new technologies. Thank you very much.
Well, thank you all for that great presentation on hypertension improvement, and want to thank you for joining this webinar today. I want to remind folks on where to go find more Davies use cases and videos, and how to also apply for the Davies Award. That information can be found posted at the HIMSS Davies Award website at hims.org/Davies.